Thanks for having me, Vivek. This is my favorite summer institute. I think this is just the most exciting one, and I say that I teach in 5 of them, so I know what I'm talking about. So the title for my talk is Navigating the Gap, where mHealth meets real-world implementation challenges. Okay, next. All right, well, I said I would be able to do, okay, good. So I like to start out with the motivation of why I began doing this and why I assume that that you guys have different reasons and probably different among you, but that some of these will be on your list. One of the reasons is it's a way to increase access to care for elderly or disabled populations or folks who live far from a clinic. It's a way to overcome distance barriers, to bring care closer to home, to help people access, even when they're multitasking, when they have caregiver responsibilities, for example. But a thing that we need to watch is that this solution doesn't exacerbate disparities. The concept of tequity is an important one here, that we want people to have technology that helps overcome disparities, doesn't worsen them. And you can see how some of this issue arises when we'll talk about things like rural populations that may not have broadband access to get some of the goodies, digital goodies that other people are getting. We think that digital health can increase education about health, knowledge, and it can increase engagement with the learning process through things like gamification. It helps people to support self-regulation by helping them track what they're doing. We as researchers get actionable insights from dense digital data. That's a pretty valuable thing. It'll come up in Billy's talk about doing just-in-time adaptive interventions. And clinically, it improves the connectivity of our care, the ability of different clinicians and different sites, different caregivers to communicate. It improves efficiency, and we hope it reduces cost and clinician burden. But ultimately, at the end of the day, I hope that we all share a motivation to improve patient and population health. That's usually the bottom line driver. Okay. So this is the translational pipeline that we're going to be working through today and also throughout the Institute. So most of us who are behavioral scientists, at least, are trained in this process of intervention development. So we start getting an intervention ready for prime time. It doesn't just sort of come out of thin air. And a lot of time and energy has been spent, especially in the past decade, on the development of good interventions. There are a number of frameworks that are used. You'll hear about the most one today, multi-phase optimization. You may be familiar with Orbit, the science of behavior change, the NIA Institute of Aging stage model. These are all things that help us develop an intervention and then optimize it so it's as effective as potent and efficient as we think it can be. We then move into the stage of evaluation. And this is where things become really important because we can't expect to have our interventions used if they don't have an evidence base behind them. And what do we mean by an evidence base? In the medical world, in the healthcare world, it basically means the gold standard is randomized clinical trials. These are very rigorous designs where you're comparing your treatment to some kind of a control of that's more or less hard to differentiate. We start with efficacy studies where we do them pretty clean. We develop these interventions in a sort of experimental laboratory context, often for efficacy studies. We only want patients who have only the problem we're targeting. They have no comorbidities or co-occurring conditions. Often our interventionists are trained researchers or trained advanced graduate students. Everything is as clean as possible. If we get a good result there, and we should, because we're minimizing error, we're minimizing within group heterogeneity that would make it hard to see a difference, we then go out to do effectiveness studies. And here's where things start to fall off a bit. We start to get what's called a voltage drop. We mess things up a little bit more to resemble the real world. So now we take patients with comorbidities rather than using trained academic staff as the interventionists. We'll probably use real clinicians, real staff in the public health sector, the clinical sector, and stuff becomes more real. You notice that I have a academic mortarboard and a diploma up here. I'm doing this because this, about through effectiveness studies, is how many of us were trained in academia. We learned within a sort of a limited structure, a kind of an ivory tower, as if you will, and our training and our approaches to intervention reflected it. What happens after that is we move into implementation research. We move into the real world because now we have an intervention that works under very clean and somewhat messier conditions, but now we want it to be used. We want people to be able to access it. We want it to be paid by insurance and so forth. And that's something that is a new field. It's not brand new anymore, but it's something that many of us were not well trained in, if trained at all. You'll see the use of hybrid designs here that are sort of filling a function of helping us do a bit of testing the efficacy of interventions while also learning something about how to scale them, how to get them used. But this is a pipeline that's important, and I'll come back to it again. If you are coming from an academic tradition, and this guy is supposed to be a professor, we, and I identify with people like this, we often have worked for entire careers to try to develop interventions that solve a health problem. They're clean, they're effective, they have good randomized control trial evidence. And then for people like me, the way I was trained, I always thought, well, if I learned how to do good, strong evidence generation and develop strong research evidence through randomized controlled trials that could be picked up in systematic reviews and shown in clinical practice guidelines, of course, these things would be used. Lo and behold, they're not. And this, you probably heard this Ballas and Boren quote, that it takes about 17 years for just 14% of research findings to translate into clinical practice. That's 17 years for only 14%. That's really not so good. And so we think of ourselves as working from the bench or the lab to the bedside to get our treatments out to people, but they have a tendency more often to go from the bench to the bookshelf, and then they kind of stay there. And that's very disappointing. It's a learning experience many of us have had. So enter implementation science. This is a model that Byron Powell will tell you more about. He will speak after me. It's probably the most widely used implementation science framework. It's called the CFIR, or the Consolidated Framework for Implementation Research. Laura Damschroeder is the developer of it. And I'm going to start over here in the academic corner because that's where I was trained. I assume that's where most of you were trained, and many of us continue to live there. So we're at a university setting or a think tank or something. We're doing research within those walls. We are paying for the research by a research grant, and we are developing treatments. This is a kind of a cutesy way of phrasing it. We're developing a thing, an innovation. In our case, it's usually a treatment for some health condition. And so because of this kind of insulated environment and the access to grant funding, many of us were accustomed to when we want to go and deliver an intervention to people, we just go out and get them. We find the patients and we learn what they need and we learn what resources they have and we deliver the treatment to them and we're good to go. The trick is, let's see, no, what I want to do is to be able, if I click again, I never did get into this clicking mode, sorry. Okay. Anyway, here we are. We got sustainability up here. The problem is we don't just want our interventions to be tested in people. We want these treatments that we develop that we think might do some good. We want them to be maintained. We want them to be sustained. Well, just think for a minute. If you're funding the provision of this treatment through a research grant, what's going to happen when the research grant ends? Treatment's going to go away. And that's how many of us grew up. We lived on our grant funding. We delivered treatments to people. The grant ended, the treatment went away, and we thought that was somebody else's job to get it to continue. The thing that the implementation scientists do is that they follow another channel. They follow this channel down here where they go through a system like a clinic or a hospital. That is a system that those of us who grew up in academia often don't know anything about. We live in the ivory tower. What implementation scientists have done is to help us understand something about these systems. They make a differentiation between the outer setting, which has to do with things like reimbursement of care, policies, and laws, what kind of external pressures an institution is under, partnerships. That's the outer setting. The inner setting is where all of the people in the hospital or the clinic work. And these are people who can be high-level leaders, mid-level leaders, opinion leaders, just plain old clinicians. And this route is much less direct because if you're going to go that route, you have to go through the gatekeepers, and then you have to get through these processes in the inner setting to work your way back up to access the patients and their resources, the patients who have needs and who also have resources. Now, the trick here is that if you actually can do that and you can get something embedded into a system in a sustainable way, it's not going to go away when your grant ends. We hope that it's going to continue to be implemented by the care delivery system and be reimbursed in that way. So this is why it's really important that we learn to crosstalk with implementation science folks. So I'm going to walk you through some of my wonderful experiences with where things can go wrong when you've developed your best try at an intervention and you're hoping it will be used. So the diabetes prevention program is sort of our gold standard in the behavioral sciences. It has big effects. It was done and developed in a multi-site trial, had incredible results. Here are the results. There were 3,234 patients in this trial. They all had prediabetes. It was a really nice representative sample, 45% minority. And what you see is that there were 3 conditions in this randomized controlled trial. There was the lifestyle condition, a behavioral intervention in which they were basically producing weight loss. Behaviorally without any drugs. There was a drug that is classic. It's standard of care for patients with prediabetes, actually for patients with diabetes, but it's metformin, and it increases insulin sensitivity. And then there was a placebo. There was an inert compound that was pretending to be a drug. And if you take a look here, you can see the results are really clear in terms of weight loss. The amount of weight loss was much greater in the behavioral, the lifestyle management group. There was some weight loss in the metformin group, not as much, and the placebo group just had no weight loss. That some of the benefit starts to be lost as time goes on. This is actually over 4 years, but there's no question what the winner is here, what the best treatment is. And it's mirrored by another clinical outcome. These people are all pre-diabetic, and they tested how long these treatments delayed the conversion from pre-diabetes to diabetes. And once again, you can see that the lifestyle intervention delayed for the longest. Metformin also delayed compared to placebo, but lifestyle was clearly the best. So what happens when you go into the inner circle of a medical setting, a clinical setting, as a person who's a behavioral interventionist who's been trained in academia? I did this about 20 years ago, and talking with lots of physicians, I said, well, have you ever heard of the diabetes prevention program? And every behavioral scientist knows this because this is our big success story. They thought, and they said, oh, is that the one that showed that metformin causes weight loss and delays the conversion to diabetes? I thought, I must have read the wrong study. I went back and looked, and sure enough, yeah, metformin was in that study, but there's no question the lifestyle intervention was the best. So I became very curious about why that kept happening. And I went back and looked at this study. This is a study on the cost of administering the diabetes prevention program compared to metformin or placebo over the course of 10 years. What you see is that the diabetes prevention program, although it worked, it produced a sustained 7% weight loss and metabolic improvement, delaying the conversion from pre-diabetes to diabetes, but it's not a light touch intervention. It's not just taking a pill. There are 16 to, depending on how it's done, between 16 and 36 treatment sessions. They initially were in person. They are still hour-long sessions. And so it's not a terribly big surprise that it costs something. It costs about $1,800 a year. And that compares to about $500 a year for metformin. We can get the costs down for our behavioral treatments by offering it in a group setting. We can get it down to about $800, but it still costs more than the drug. So I think that that the physicians I was dealing with and the physicians in leadership positions at that institution looked at this and said, no, this is not practical. It's not efficient. It's not a good use of resources. So we then have the challenge of saying, okay, if we want this to be implemented, we need to make it leaner and meaner. We need to make it more efficient. So how do we do that? And this has been an arena where we've been developing methods to learn how to do that. Because when we started, we just had a kitchen sink of components that took 16 to 36 sessions to administer. And I think this tends to happen because we don't, as behavioral people, often get a chance to do clinical trials. So when we finally do get a chance, by all means, we want it to work. So we throw the kitchen sink at it. And the DPP and the subsequent program, Look Ahead, which was for people who already had diabetes, had all of these things in that kitchen sink: 24 to 36 treatments, treatment in person, 60-minute sessions, cost $1,800 per year, just for a year. The counselors were health professionals, and in Look Ahead, the one for diabetes, they actually gave people their food. They gave them meal replacement. So, okay, but we had no basis of knowing, okay, we know we want to cut it down, but what can we take out and have it still work? So this brings up the point that the first thing that we had to learn to grapple with if we wanted our treatments to be used is we had to be able to make a business case for why somebody would find this worthwhile. Why would they want to pay for that? It's burdensome, it's costly, it's not very efficient. The clinicians have to keep doing these treatments, the patients keep having to show up. So what can we do about that? Well, some of the methods that we developed are things like this, the MOST methods, the multi-phase optimization strategy. And this is one of the first ones that appeared, the MOST factorial design. And so what it lets us do is to take those components and to turn each of them on and off and see what makes a difference, what really improves weight loss, and for what price. So what we're doing is this is called a screening experiment. We're optimizing the treatment for the context that we're in and the constraints that we have. So the way we did this is we compared two different versions of the number of sessions. We gave half of the people 12 sessions and half of them 24. If there was anything that I thought was going to have an effect, it was that, because people are so expensive, I was sure 24 would be more effective. We turned on or off whether we gave them meal replacements, whether we gave them text message reminders and supports, whether we sent a report of their progress to their primary care doc. We enrolled them with a buddy, a support buddy, and we turned on and off whether we trained that buddy to be supportive. And we knew that our optimization criterion was we wanted to be able to have a treatment that maximized weight loss for less than $500. And you can see the contender treatments here. And indeed, whoops, here we go again. Okay. The one that is the best fit is this top one. Costs less than $500. It's got a pretty amazing outcome. About half of the sample achieved 7% weight loss. 5% is our clinical goal. I don't know. To believe I work with technology, and yet here I go. So that's a pretty good outcome. And take a look at what's going on. We found in this study that it made no difference whether people had 12 or 24 sessions. 12 worked as well as 24, and 24 is a whole heck of a lot more expensive. So we'll use 12. We used the buddy training. We used the PCP report, and we got that really lovely result of half of the sample achieving a clinically meaningful 7% weight loss. But there is there's another approach that we could consider, which is this bottom one. Number 17 has the green thing around it. And that one has basically everything turned off except for the 12 sessions. It doesn't yield quite as good a weight loss. It's about 1 kilo less. But still, more than half achieve a 5% weight loss, which is also clinically meaningful. And that one saves about $100. So that gives us the ability to have some play in the intervention that we're using. If we find that cost is a barrier, and I'll tell you right up front, it is usually the number one implementation barrier. If it's a huge issue, like if you're working at a federally qualified health center, it might be the one that you would elect to use. So with doing that kind of work, we've established that the diabetes prevention program can be scalable. It has policy evidence. It was reviewed in its original form by the U.S. Preventive Services Task Force, which puts out evidence-based practice guidelines. And as a result of the Accountable Care Act, it has to be reimbursed with no copay because it has got such a high quality of evidence. Lots of energy was put into disseminating it. The CDC developed trainings and a certification. It was disseminated very widely. People went and got trained. And because the uptake was not what we wanted it to be, they tried to disseminate it through channels that were closer to the community. They offered it through YMCAs. They now have an online version. It still is mandated to be covered by insurance. So how is it doing? How is it scaling? What's its reach? Well, less than 0.5% of the population of 96 million US adults with prediabetes have accessed this treatment. So the uptake is terrible. It's just really terrible. We developed it. It has a good evidence base. We put it out there, and we had all the implementation outer circle support behind it, but it didn't scale, didn't work. So that's what pushed us back to the studies I've just presented to you on. Most came after the diabetes prevention program had been pushed out and scaled, but it wasn't doing very well. This sent us back to the beginning to further optimize it. And I bring this up because very often we think of treatment development as a linear pathway. It only goes in one direction. But in fact, very often we need to learn that sometimes things are not working well, and we need to go back and sort of dismantle and reassemble the wheel. So that's what we've been doing. Okay, another case of trying to get something taken up into practice. As you can tell, I work in chronic disease risk behaviors. Obesity is one of them, poor quality diet, physical inactivity, smoking. And I directed a cancer prevention program at a comprehensive cancer center for about 20 years. And a great frustration to me was the fact that none of the treatments that I was developing could reach people. Okay, now I have to move this way. So these are some of the things that we develop treatments for. I was particularly interested in the fact that they don't travel alone. They tend to travel in bundles. So we did studies trying to target multiple dietary and physical activity risk behaviors at once. And we used mobile technology in these interventions to help people track and to be able to treat them at a distance. We then did the weight loss studies that I've just told you about. And then we went on to try to get our cancer work scaled. Now, this is a whole institute on mobile health, and I've really not shown you any mobile health tools up till now, but I'm showing you this just to let you know, yeah, I work with mobile health tools. So these are the ones that we are some of the ones that we've developed over many years. You can see we started working in Palm Pilots when they were cutting edge technology. We went on to Android and iPhone. We had accelerometers that Bluetoothed to the app and gave people feedback on how much physical activity they were having. Same thing with their dietary intake. They would input what they were eating. That would show up in terms of how are they doing in terms of their calorie and fat gram allowances and their physical activity goals. Eventually, we got to incorporate things like wireless scales, which also Bluetoothed back to the app. And the app Bluetoothed all of these data to the coach so that the coach was informed when they were coaching by telehealth, and they could see what was going on, whether the person was tracking, how they were doing. So that's the mobile health component of it. Okay, so now back in the medical community, I'm leading a behavioral cancer prevention program. And the only other part of the cancer prevention program is the biomedical one, the one that involves drugs. And we know what the major risk behaviors are for cancer, and they're also the same for most chronic diseases, so our cardiovascular disease and so forth. They are things like smoking, excess body weight, physical inactivity. And we know that 40% of cancers in the US are attributable to these modifiable risk behaviors. About 20% is due to overweight, poor diet, alcohol, and physical inactivity. Those are the big ones. So I was once again approached by lots of my colleagues saying, well, why do you study these things? What does that have to do with cancer? Well, you'd think people would have heard of the smoking guidelines, that the Surgeon General's report, but this was an issue. So here's the context that we work in. 45% of older patients, who are on Medicare, have at least 4 chronic diseases. Patients with chronic diseases account for 90% of total healthcare expenditures. Our care delivery is reactive. We tend to wait until the disease develops, and then we treat symptoms and we manage the disease. So why don't we try to prevent by treating these risk behaviors that are major causes of chronic disease? Well, think about that for a second. It has to do with some of these things that are in the outer circle. And it took me a long time to realize this. Think about the position of a health insurer. Yeah, you'd like to keep people well. You'd like to get everybody healthy. But it's going to cost you some money to do that. And when is the payoff going to come? It's going to come because you're going to reduce their likelihood of developing disease. But there's an issue here because we're not a single payer healthcare system. A majority of people in the US, still about 69%, are on private insurance. And we shift our insurance. The average change used to be about once every 2 years. Now it's between 2 and 5 years. And insurance is a business. There is no insurer who wants to make an investment in improving somebody's health if they're going to be on somebody else's plan by the time that the benefit in terms of preventing hospitalizations, preventing multiple emergency rooms and visits and surgeries is going to come due. So primary prevention is a very tough sell in cancer. Where are we here? But, and this is, again, thinking like a researcher, but also going for the outer circle aspects of things. Fortunately, we have cancer survivors. Our cures have been good enough that we now have many people who live through cancer. And these risk behaviors don't stop doing damage once somebody has had cancer. They continue to cause a increased likelihood of a new cancer or of cardiovascular disease. And we have enough cancer survivors that they've advocated very heavily that we now have guidelines that say quality cancer care includes not just treating the disease, but also promoting long-term health and quality of life. We have guidelines to that effect. These are the national and the NCCN guidelines. These are the ones for patients, but they exist for physicians as well. And they're all health promotion. It's all diet and physical activity, sleep, healthy lifestyle. And clinicians are supposed to be following these. So are they? Well, we started by interviewing oncologists, surgical and medical ones, general practitioners, and specialists who address different kinds of cancers. And here's what they told us. For what % of your patients who are cancer survivors do you recommend ways of improving their lifestyle, like quitting smoking, losing weight, or increasing physical activity? Well, this was eye-opening. The general practitioners were the most likely to recommend lifestyle change. But the really striking thing was the groups that said none. They never do this. There were almost no primary care docs, like maybe 10%. About 73% of oncologists, even though this is their guidelines, said no. Even though they're supposed to do this, they said, no, I don't ever do this. Specialists were even worse. 90% of them said, no, I never do this. So that was eye-opening. Are these practice guidelines that we trialists have been trying to get into, are they doing any good? Well, we asked another question. We said, well, maybe they're not helping because they think it's just a cosmetic concern. It's not really a health concern. So we asked, if an overweight cancer survivor asked you how they could become healthier by losing weight, what would you do? The primary care docs all over this agree on a healthy weight loss goal and advise the patient to use an app to track their calorie intake. The worst were the specialists. Tell the patient, I don't discuss matters that are not in my area. But the oncologists were not so great either. They said, since their cancer is the most important issue, I would tell them that staying in remission is their most important priority. So again, they're not doing what the guidelines say about trying to ensure the good quality of life and the longevity and healthy period of life of their survivors. So why was that? And really what it comes down to is system, financial pressures, and role issues. So what the oncologists say is I think somebody is unmuted, maybe. Okay. They say they've got tunnel vision, basically. They're so focused on the life or death aspects of cancer that everything else falls through the cracks. Well, basically they get ignored. It's going to require a different way of thinking for the oncologists. The oncologist is going to have to say, you mean I have to pay attention to that kind of stuff? All along, my role has been, we don't have to worry about that right now because I'm just trying to keep you alive. The production pressure that they're under, they're on a kind of an assembly line. There's a lot of stress to produce, generate revenue. Their RVUs see as many patients increase access for patients, increase billing. You can't have a sit-down conversation with somebody for 15 to 20 minutes. That's another 2 patients. It's not their role, and they're not going to be able to pay the rent if they do that. So, what's not to like about all this lovely evidence-based stuff that's paid for by insurance? Well, it doesn't work very well in the inner circle in terms of the care team's roles, in terms of the workflow. They don't have time to do this. And in terms of relational communication with the patient, they don't know how to talk to a patient about this stuff. They weren't trained for it. So let's take a look at what other kinds of options we have. This is just a slide showing the prevalence of risk behaviors in the cancer survivor population. About the highest percentage for a risk factor is the overweight obese one. It's about 69, 70%. 52% have 2 or 3 of overweight, obesity, not being active enough, or smoking. Smoking is the one we've done the best at. It's gone down the most. Being not active enough, about a third of us are that way. Now, the first thing to think about is if you're going to go in and you're going to try to treat these behaviors, how are you going to know who has them? Now, weight, we can tell. We take that as a vital sign. It's usually in the chart. Smoking, we've gotten a little bit better at. When was the last time you saw a measure of physical activity in a patient's chart? No, you don't see it. So the first issue is, how are you going to know this? Is it a priority? Is it well incentivized? Is the payment for it very good? What's the culture? Do we want this to change? So this is a trial that we're working on now. It's a P50. It's an integrated, pragmatic trial, integrated healthy lifestyle program to live well after cancer. The aims are to integrate telehealth cancer behavior risk factor assessment and treatment into cancer care processes across 11 hospitals in Chicago at Northwestern. So part of how we're trying to address this question of how do I even know what risk behaviors you have is we have patient-reported outcomes that people complete at intake that say whether they smoke, we know whether they're obese from the chart, but they also assess physical activity. So at least we'll know that. Okay. Some of the things that we've done to try to make the treating of these things more accessible, more convenient, is we've tried to deal with some of the inner circle's system barriers. A major one is always cost. I said it's always the first one. The way that most behavioral people were trained to treat risk behaviors, we specialize. It's common for somebody to be an expert in treating weight loss, somebody else to be an expert in treating smoking, and a third person to be an expert in treating physical inactivity. What do you think is the likelihood that a hospital is going to want to hire 3 PhD level lifestyle interventionists? It's not going to happen. It's too expensive. So one of the first things that we had to do was to figure out a treatment protocol that would let a single interventionist be able to treat all of them, which we did. We have a unified treatment protocol that treats all 3 of those behaviors, applying uniform strategies like motivational interviewing, self-monitoring, and so forth. That was the first thing we had to do. Second thing, of course, you could just tell that the management would be screaming about cost. They don't have staff that are trained to do this. They don't have resources to hire all these experts. The people who they do have don't have time. The reimbursement isn't good enough. So what we did was an implementation strategy called creating a new role. we created a bachelor's level health promotionist. This person is supervised by licensed clinicians, but they do the coaching and they also give warm tech support, which has been another issue with mobile health. With mobile health, you usually have to train your disadvantaged folks, which means elderly or folks who don't have broadband or whatever. You have to train them to use these technologies. Well, our bachelor's level coaches are trained. They give warm tech support as well as doing coaching. Okay. So that overcomes a big resource burden. Treatment delivery. This is a big issue for patients. They often have to travel to get to where they would have to get in-person treatment. There are logistical costs for parking and so forth. So we do this treatment by telehealth. That lets patients access much more easily. It also eases clinician burdens because essentially we're outsourcing the treatment. It's not getting in the way of workflow. And I show a chair here because very often when you're trying to do this in person in a clinical site, you can't even get a chair for your coach to sit in. So we are able to get lower cost rental space and do the treatment by telehealth. We also, as I've mentioned, we use these most methods to optimize the treatment so it's more efficient. What are we doing? These are the 11 hospitals where this is being rolled out. They're all integrated by a single electronic health record. So we search the data warehouse to find our folks and we approach them. It gives us equity. We're not sort of having biased referral. But you see these issues about staff appointments, about who's going to supervise, who has EHR access. These are tricky issues. Okay. Institutional barriers. This is a tricky one. Insurers are starting to allow more outsourcing of treatment, which is a way of lowering costs, but it's still not all that common. We had to cross institutional lines to get this intervention to happen. Our coaches, our health promotionists are, on the university side of the house. They are doing the coaching and the tech support to the survivor. The survivor is sending the information about, well, they're sending their app data to the health promotionist who's monitoring. But we also don't want to be doing this ourselves. We want to be working through the inner circle. So we want the oncologists involved as well. And so we had to figure out how did they want to be looped in and how could this information be presented to them. Our first thought was, great, these people are wearing Fitbits. We can get the Fitbit data just transmitted into the EHR. Think again. We did a lot of qualitative work with clinicians, looking at how would they like to see these data? Would they like to see progress over time? They said, no, they're so time pressed that it would take too long to look at time course data. What they want, this is what they wanted. They wanted to get an in-basket message from us that was basically a crib sheet. It told them, how's the person doing? They've got several goals, a weight loss goal, physical activity, smoking, and are they coming to treatment? It would tell them whether they were achieving or not achieving, and then it would give them a crib sheet for what they could say. How they could congratulate the patient if they were doing well, how they could encourage them to do better if they were not. That's what they wanted. They wanted to look good, and they didn't have time to do anything more than that. We learned in the course of this that there were some very interesting things about how we had to frame our intervention messaging. We found that survivors, and from the patient interviews that we did, they really do not like terminology about risk behaviors. They thought it blames them, makes them feel responsible, and it's discouraging, it's demoralizing. What they wanted was positive language. So we script all of our materials to them to talk about health promotion, regaining health. We never talk about risk behavior change to them. On the other hand, our qualitative interviews with the oncologists said, don't talk to them about health promotion. Health promotion to them means that the psychologist needs to do something. Talk to them about risk behaviors. That means that an oncologist needs to do something. So we literally optimized in the inner setting in our EHR messaging, two different ways of messaging depending on who the constituent was. Was it the provider? Was it the patient? Okay, I am gonna wrap up. I think the important thing for us to bear in mind is that mobile health, digital health in general, is progressing through a really rapid transformation process. We've gotten a lot accomplished in terms of understanding how to make things more user-friendly, using user-centered design, using methods to optimize interventions. And we're learning now rapidly about implementation science, how to get things out of the academia and into settings where they'll stay, and where clinicians will value them and insurers will reimburse them. There are a lot of translational barriers, but it's been interesting that we have been able to find workarounds. And some of these things are not so different than some of the things that we learned in academia to work around those systems. And we'll get better at it as we go along. But importantly, we can't think of this as a linear pipeline. It's not just we develop things, we test them in randomized controlled trials, and then we send them out into the world and they stay forever. Change is inevitable. We're going to need to adapt over time. Things that work now are going to stop working, or they may not even be taken up now because they're not appealing to the gatekeepers. We need to also have the ability to go back, re-optimize, and iterate to make things work better. So I am out of time, and I will thank you for your attention and stop there. Should I take I will take the slides down. Okay.
Okay, all right. I was trying to figure out how to unmute. We'll take some questions. Also, keep in mind Bonnie is and will be there at the in-person meeting. If you have any follow-up questions, we can set up a coaching session with her. Are there any questions? Feel free to use the chat. Are there questions? I see some.
I had a question. Is it okay if we just ask directly?
Sure.
Yep, please.
All right, so thank you for the talk. It was really interesting. So my question is, I know you mentioned that sort of for secondary prevention, there's a little bit more buy-in with sort of the inner circle. Are there any sort of strategies that you found helpful for kind of getting that buy-in for some of the primary prevention that you mentioned was kind of difficult?
Oh, this one is really very difficult. I think the place where I think there's been the best uptake is in the child space. And it's partly, we try to do right by our young. So there's that sort of that investment. But I think it's also been partly a secular trend. We see diabetes in elementary school kids now. We see fatty liver in elementary school kids. So, I mean, it's like you're sort of coming in already too late to be doing primary prevention, but you are getting a fire lit under that you better do it now if you're going to do it anytime. Frankly, in terms of getting cancer prevention work funded, you can get it funded in the public health sector, but you can't get funding for the kind of work that we tend to do. And, as somebody who's done technology assisted interventions for most of my career, I continue to run a horse race between, okay, can we get the technology to do it itself? Or do we need a human in the loop? So far, we've still needed a human in the loop. Now, chatbots are getting close, but they're also a little bit scary. So, when you're talking about needing a human to do some of these changes, it's costly. So, but we have found that working with survivors is the best way to bring it home, and also because they have been very effective advocates in the policy space.
Bonnie, what a wonderful start to our 2026 MHTI. I thank you very much for all that.